Welcome to the For Health's Sake podcast, brought to you by Edito Health, elevating digital transformation with a human touch. This episode is sponsored by Radical Health Festival. It's critical to be radical.
Hello, my name's Charles Alessi, and welcome to this edition of For Health's Sake. Today we're going to talk about a subject which has become ever more current as medical technology and complexity has increased over the years, and that's clinical decision support. Because, of course, nobody, even the best physician in the world and health worker in the world, can ever possibly hope to remember everything to do with an appropriate guideline for an appropriate person, because we're all so different. Now, to delve into this subject a little, I'm joined today by Rahul Goyal, who I've known for some time. Rahul is a physician, and he is the medical director for Elsevier. And Elsevier, of course, is the company which produces so many of the journals we know about, everything from the Lancet to a whole host of others. So welcome, Rahul. And would you like to introduce yourself a little and give some sense of your experience very quickly? And then we'll really delve into the subject.
Thank you, Charles, and thanks for hosting me. So yes, my name is Rahul Goyal. I am practicing GP, and with a surgical background, used to be an ophthalmologist before got bored doing cataracts. I've taken up the role as the Chief Medical Officer for Elsevier Clinical Solutions for our global market, or international markets as we call it. It's been an exciting journey from having got the affliction for digital health about 14 odd years ago, through NHS Choose and Book, and transitioning into electronic medical record, workflow enhancements, health information exchange systems, and shared care records at a population level in the Middle East, to now into clinical solutions for the clinicians. That really matters.
I mean, it's a pretty logical, actually, transition, isn't it? I mean, you first got the bug, which is terribly infective, of being interested in digital health. And at the end of the day, you came back to where you started, to being a physician. Because, you know, physicians will never be the best engineers, because they're physicians, not engineers, even though some of them are quite extraordinary. But I mean, I think that's a wonderful background, really. And clinical decision support has really changed, hasn't it? I mean, as you know, but I know better than you for one reason, because I'm much older. When I was a young houseman, we only had half a dozen guidelines to follow, really. And to be frank, we only used half a dozen drugs, really. Drugs for heart failure, drugs for, you know, ventricular fibrillation, and painkillers. There wasn't very much we used. And in essence, what we did when we were on call in emergency rooms is we made sure people were free of pain. We made sure people were comfortable, and we put them to bed until the next morning, when we then decided what happened next, sort of. So in essence, it was a relatively simple, it didn't feel like that at the time, but compared to now, it was very simple. Now compare it to today. So how do you think clinical decision support has evolved over the years because of that?
Yeah, I think a decision support, even from the years that I was training in the early 2000s, was more of having your British National Formulary or the BNF on your shelf.
Yeah.
And consulting it like a physician's desk review, really, for when you need it, because EMRs, having that maturity, wasn't really there. If at all you had an EMR to start with. Those sort of positive nudges were important to make sure that you don't, first do no harm. And I think that's the what I call the last mile care delivery part, which is you can have all the knowledge in the world, you can have you could have read all the books that you wanted and been up to date with all the journals. What really matters is how cognitively you combine that when the patient, the real patient, is in front of you, and apply that for the last mile care delivery, which I call the prescription or the order of test, you know.
Yeah. Yeah. Do you remember the pediatric vademecum? Were you carrying it around in your little pocket? It actually fit in our
Right.
white coat.
Exactly. So they were actually designed to fit in the white coats. And I used to even carry my Oxford handbook in my white coat, you know, because it was compacted to the size. And that was literally our decision support. But what you just said about guidelines being fewer, not just being fewer, but being shorter. I mean, a nice guideline nowadays can run into a few hundred pages.
Yeah.
And try to get an actionable insight out from that requires a lot of tenacity and persistence to read through. It still doesn't let you have the actionable insight for the patient in front of you if they have complex care, which is abundant at the moment. And the side effect of that, of that's a perfect storm, I feel, for clinicians who are delivering care on the front line, because that cognitive overload leads to their burnout.
Yeah, I mean, you have multimorbidity associated with aging, of course, and nature being what it is, as we're growing older, inevitably multimorbidity is a fact of life. And coping with multimorbidity guidelines is actually really complicated. As you know, as I know, frankly, it's a nightmare.
100%. And I think what keeps the clinicians up in the night, and I've had multiple debates about this from with non-clinicians, and a lot of times it's assumed that what causes our burnout is that extra patient load or reaching home a bit later. When I speak to colleagues and when I'm in my clinical space, I don't think that's what causes my burnout. My burnout is from, or my sleepless night is from, have I done the right thing for my patient? Could I have done something better? Could I have asked anyone else? That reassurance that I seek, you know, is really important for me. Have I applied the latest and the greatest knowledge with best clinical outcomes that day?
Yeah.
And that's where it lies and that's where the perfect storm lies, with complex care becoming more complex. And the information, what we call in the Elsevier world, the infodemic has worsened. So to filter out the noise, apply actionable insights to complex care is a very arduous process for cognitive stability.
And some of the solutions which people came up with in the very beginning of our journey towards getting really our pediatric vademecums and our Oxford into the digital space was that what we got is a translocation of the book in a digital form, which is fine, except how on earth you fit that in a clinical flow, especially if you're overburdened with activity. In other words, if you've got patients coming in regularly, it takes you ages to figure out how to find something and ages to actually try to figure out how to apply that to an individual.
100%. And that takes me back to that bit about the actionable insight. Now, an actionable insight is subjective. For me, an actionable insight is something that I can act and work on imminently now. We know that there is a sense of urgency in clinical care. We don't have the luxury to read journals and books in between patients. We have that urgency is what is part of the burnout. The urgency, not just to prescribe, but to make sure that you prescribe well, you prescribe best practice and evidence-based. It isn't possible to read a chapter in a book in that urgency and the fluidity of a clinical situation to apply it, for sure.
So, I mean, we are then in a situation where suddenly all the bits which we could potentially need are starting to come together, because what was lacking perhaps was the ability to actually ask a question and get an answer, which is really, you know, a clinical question, and really look to the answer, which really was my greatest need when I was a young clinician. But of course, there is a danger here, and that danger is that it's the same as just Googling something. And for all I know, I'll be told that having 10 raspberries a day is the best treatment for left ventricular failure. And that may not necessarily be the right thing to do. So how do you manage that process in clinical decision support systems?
So you're absolutely right. I mean, the credibility and where your curated data comes from, the trusted resource slash partner, if you like, is probably more important than how you get it. You can nowadays, with the infodemic, as we spoke about, it's very easy to obtain information. How trusted and credible that information is
well, that's fundamental. Yeah,
between correct care delivery and not so good outcomes. So going back to something which you touched on very importantly is the textbook that you started having on your desktop, but you still have to cognitively lace together the patient's complexity and comorbidities into a condition that you knew how to treat. Not so much though that for a specific patient in front of you. I'm more than happy to show you an example on.
Oh yeah, we'll get to that in a minute. But before we get there, could you help me understand how, because Elsevier have come up with a product called Clinical Key, which I think we're going to have a look at in a minute, because I think it's quite interesting. And really, it can potentially be used in the clinical flow, and that's the biggest advantage, clearly. Now, how do you curate the data? Where does it get its data from? Because that is the first and most fundamental question anybody would want to know.
Yeah, so and that's the pertinent question here, and it's quite key for the physicians and the nurses' trust in the system. So all the data that is indexed into Clinical Key and Clinical Key AI comes from trusted textbooks like Braunwell's Cardiac, Nelson's Pediatrics, just to name a few. We get journals that we have published for several years now.
Probably longer than you've been alive, mate. What do you mean several years?
Slightly. Yes. Well, Elsevier as a company is from 1800s.
Yeah. So yeah.
It's got a legacy, and it's got data that has been, so the clinical content, we are fortunate to be custodians of one of the largest clinical contents in the world.
Yeah.
And we take that as a big responsibility as well, to make sure that any solution that is surfaced by Elsevier stays true to that trusted partnership that we've had with the clinicians forever. There's journals that are published not just by Elsevier, but also by our partner organizations that we have MOUs with. So it's not limited to only Elsevier content. Not to forget, we also do something called a clinical overview, which I'll show you in a minute, on Clinical Key, which is the traditional portal, which is currently available to several institutions all over the globe, which is a synoptic editorial content presented on a topic, which includes journals, articles, textbook extracts, not limited to Elsevier publication. So what you get, in short, is more than the sum total of what you get indexed individually.
Let's have a look. Let's have a look at it, because I think it would be worth having. And just let's put in a problem of a 62-year-old guy with pain and with let's think of a problem for somebody.
Let me just show, just for the sake of showing the difference that we have. I'm just going to share my screen. I don't have a bar to share. Let me just try this one, and I should be able to now. Okay. Right. So I hope you can see my screen.
Yes, I can.
So this is Clinical Key. This is the portal that is currently available for knowledge discovery to around the globe. This is not our latest solution. I'm just showing you an example of how knowledge is usually gathered till now. This is as is current world. So if I want to go and look at palpitations, to the case that we were just talking about earlier, I can go to a clinical overview and I can go to a summary, or I can go and see well,
Yeah.
do I diagnose one and
Yeah.
a work and a differential diagnosis?
I mean, that's useful, of course, but the reality is that is useful in a proportion of cases.
Correct.
And it does interrupt the clinical flow to a degree, not because there's anything wrong with it, but because I'm really keen on us showing what is possible in terms of asking a fundamental question. And we discussed the potential question a little bit earlier. This is live.
Yeah, this is live. So
here we have a typical presentation, a very typical presentation. Somebody had palpitations, everything else is normal. What could be the cause of this? And I think that's something which we see in practice not that irregularly. So let's see what we come up with.
So this is more conversational, and it's more than just searching a topic. This is now pertaining to a person who's a certain age, with a certain occupation and profession, which has an impact on the diagnosis. And that is how actual life works in our clinics. So what clinical key AI does is it looks at various data points, palpitations, normal ECG, the blood pressure is normal, and the fact that better at home, no cardiac problems, and tries to look at our trusted resources to bring up potential differential diagnosis that the person might be having. The beauty is it stacks up the ones that are more significant at the top, and it then goes down the food chain, if you like. Every time it suggests an answer, it strings it with a reference next to it.
But I mean, the reality, Rahul, is that when you were training to be a practitioner, when you met a situation like this, what did you do? You went next door to ask the senior partner or somebody who is more experienced. So, and in essence, we have replaced that. That's what I find most attractive. This is very human. And the approach is something which fits within what we do.
Correct. And it's I say that a solution like clinical key AI is like an assistive tool. It's not replacing your clinical knowledge and judgment. It's that assistive tool, no bigger than a stethoscope that you use in your clinic. But it presents you what you possibly know and what you might not know, which is very important.
So I think this is really quite impressive. But let's now, because I think it's important we're realistic about the journey, and the journey really is potentially at some point in the future we need to get to a place where what actually happens is the system immediately does this for you the moment you start consulting with a patient. In other words, it integrates within the clinical system. Now, I have mixed feelings about that because of the accuracy of the clinical record. What's your sense around all this?
I have a pros and a cons list in my head of integrating such a system into an electronic medical record. The pros being slightly faster discovery of knowledge because you already have the demographics and the data points.
And more personalized potentially, of course. Yeah.
Precisely. And if you can integrate the lab data points from the lab information management system, potentially the radiology report, if not the images. Medication discovery is faster as well. And the patient's current comorbidities and presenting diagnosis. So this shortens the search, if you like. That boon is also the bane of it because electronic medical records traditionally don't have the latest and the greatest or the filtered version of the patient's condition. So a lot of times, well, 9 out of 10 at least, when I practice, I see DVT that the patient has, which is like a leg clot, clot in the leg from last year, still being present as an acute problem because no one's bothered to put it as a past.
It's curating the record, which is the issue, isn't it?
And that kind of sends a blemish to your search. I would rather not have that piece of information. the time it will take me to validate what's relevant and reduce and take away what's not relevant will be more than asking a question from start.
I think it's a real dilemma. I mean, I've been struggling with this. It's a real dilemma because intellectually, of course, it's got to be integrated, but it can only be integrated in a fully curated, accurate, real-time medical record of a human being. And I know in clinical practice, even though we're really getting much better at ensuring that they are complete, we are not getting better at ensuring they are current, because things, once they're there, aren't removed as assiduously as they should be. You're absolutely right. And I think that's potentially quite dangerous, actually. That's my worry.
Absolutely right. And I think there needs to be another AI running and filtering our EMR with clinical rules, obviously, and not relying on the clinicians to filter them, because that's an admin task they can do without.
Yeah.
but yeah.
So this is a wonderful, wonderful journey. And thank you for spending a little bit of time really trying to get into this new world, because help us get into this new world. Because I think here we've certainly made really quite remarkable progress compared to where we were, which is the book in my pocket, which actually fit in my white coat. And I think the outcome of this, of course, is better outcomes for people, and hopefully a more constructive and less burnout for clinicians who are trying to cope with the complexity of today. So do you have a final thought before we meet again in Helsinki in a week or less?
Less, yes, absolutely. Looking forward to that. I think if I was to summarize my thoughts, and I'm very emotive about this because I also work as a physician. It's the value that clinical AI as a solution adds to the last mile care delivery is the fact that it's not a black box. It's a transparent application of an AI use case, surfacing, not creating, surfacing the knowledge in our books and journals that I would have got, but taken a lot more effort, time, and the loss of my cognitive gray cells. So I think it's a journey, it's a new journey, but it's very exciting from onwards from here.
Yeah, I couldn't agree with you more. Absolutely fantastic. So we continue this conversation in a couple of days.
See you soon. Thank you,
Thank
Charles.
you.